Well, welcome back, everyone, as it's now time to begin our last session of the day. So I have the pleasure to introduce our chair for this session, Stephen Allen from the Validity Foundation. Stephen has an extensive experience of advocacy and in the disability rights space, particularly in the context of people with cognitive disability and intellectual and psychosocial disability. And we're very pleased to have the Validity Foundation as part of our event for today. So Stephen, over to you to chair this final session.
Thank you very much, Eleanor, and also thank you very much for the invitation to take part in this really important event. Firstly, let me just start by recognizing the incredible efforts of the response team and the outcomes of this really important research. I think I join many of the previous speakers in that call for action to ensure that there is better protection of the human rights of persons with disabilities in situations of emergencies in the future. This is really, really important. In this context, let me just briefly loop us back to the very beginning of the day and Terezia's most incisive keynote speech. Build Back Better can't be about going back to the good or the bad old days. It is incumbent upon states to adopt more inclusive policies grounded in those concepts of inclusive equality and inclusive autonomy. And so I'm very lucky to be chairing this panel where we will be looking not just at the lessons learned, but also at some of our recommendations going forward. It's good timing for this because the CRPD committee is also now working on a general comment on Article 11. So I think this event can actually contribute to that process. I'm joined by a wonderful panel, each of whom have 15 minutes to provide their remarks, following which we will have 15 minutes for questions and answers. I've been asked to let you all know a couple of technical points. The first is that one of our speakers, Hernan, who will speak third, will be speaking in Spanish. So you will need to select interpretation, which you can do by clicking on the globe icon at the bottom of your screen. And also for the final Q&A, if you cannot use the Q&A box, please just raise your hand and we can open the microphone so that you can deliver your comments or questions verbally. So with that, those brief opening parts, I'd like to firstly introduce our first speaker, Dr. Maria Laura Serra. Laura is a postdoctoral researcher at the University of Valladolid in Spain. Her project focuses on the Spanish mental health system, aiming to develop public policies and legal changes that respect and guarantee the human rights of persons with mental health issues. And she has huge international experience that she brings to bear on this, as well as a commitment to intersectional feminism. Laura, please, the floor is yours.
Thank you, Stephen. Many thanks to Eleanor and the whole response team for kindly extending the invitation to be here. Moreover, I am sincerely grateful for the insightful discussion on such a vital subject, like Stephen was saying. I have gained a wealth of knowledge today, and I would like to express my gratitude to all the panelists for their excellent presentations. And I would like to start saying that to build a framework for political, legal, and social measures that treat people with disabilities equally, even in context of emergencies, we must first acknowledge that not everyone comprehends the values that underpin the CRPD and what it stands for. Many people in positions of power may not fully grasp these concepts, which can leave disabled people's rights vulnerable. So those of us who work in the field of disability rights often take certain ideas and issues for granted and keep moving forward in the discussion. So I believe that the COVID-19 pandemic has highlighted this issue clearly. While I cannot accurately measure the social impact of the COVID-19 pandemic, it is clear that the world has been forever changed And this crisis has revealed the best and the worst aspect of societies and individuals around the world, exposing both the positive and negative aspect. While there have been reports of corruptions and individuals in positions of power receiving preferential treatment, such as priority access to vaccines, that this happened in my home country, in very far away, we have also seen inspiring examples of individuals and communities supporting one another. These events have highlighted the significance of our individual and social values and give us some lessons. So to provide a comprehensive overview of the lessons learned from the COVID-19 pandemic, I will try to categorize them into two groups: structural, that I mean with structural, the state, and maybe more practical or tangible lessons. Later on, I will offer recommendations that are more reflections based on these categories. I know that extensive research was conducted by the response team on this topic, and they have shared valuable findings that have significant social and legal implications. Mine are only superficial and don't pretend to be exhaustive whatsoever. Firstly, and while it not may be directly relevant to our current meeting, I would like to briefly reflect on a philosophical aspect, the balance between paternalism and autonomy. Particularly during COVID-19 pandemic, it is worth considering how restrictive measures may have impacted disabled people differently. Paternalism in healthcare often involves evaluating a person's competence, but it's important to question whether this comes at the cost of restricting their autonomy or even deny the legal agency. Some authors discuss the use of paternalistic measures to justify actions. There's an author, Basford, that have a study that focuses on medical paternalism and concludes that it can only be justified if it does not violate personal rights and has practical benefits. He believes that medical paternalism is only necessary when the person lacks full competency. So one question that arises here is who benefits from a paternalistic practice, or in other words, why paternalistic measures during COVID-19 were applied to disabled people mostly. Here we could discuss negative and paternalistic stereotype as well, but these are out of the scope of today. However, these type of discussions also cover the practical implications of restrictions, going beyond abstract discussions to real world situations that I would like to address. One is that the general population has had first-hand experience with restrictions and is now more aware of their impact. This has sparked conversations about what it means to be isolated, live under rules in shared spaces, and not to be able to socialize freely. Another is the conversation that occurred perhaps to a lesser extent than the first regarding institutions. In Spain, particularly in Madrid, older people were left to die in residential care institutions. They were abandoned, and at the same time, inconsistent restrictions on institutions for disabled people were provided with a lack of clarity. The restriction is inherently inconsistent from my point of view, at least, but during the COVID-19 pandemic, what surfaced about restrictions often had to do with the abuse and torture to people. So in this regard, I believe that the COVID-19 pandemic has affected this questioning of institutions by society as a whole, or at least it is present in the collective imagination. Currently, there is a discussion among service providers about lifting some restrictions. This shift in attitude shows a growing cultural awareness as people start questioning previously accepted practices. So COVID-19 may have sparked a more thoughtful approach that encourages staff working in institutions or congregation settings to consider the impact of their actions on others. And the third discussion I want to bring attention is focused on trauma. Since the COVID-19 measures were implemented, people have become more aware of the impact of isolation and restrictions, which can be traumatic. And here a fourth notion that I will briefly mention as it falls outside the scope of this study. Recently, I have a conversation with Bill from the UK about trauma and restrictions, specifically regarding something called therapeutic restrictions. So this type that I believe are euphemism are usually used to describe complex issues which violate basic human rights. So disabled people are segregated from communities, and even in institutions, they are often isolated from the rest of the so-called residents. So it's nothing therapeutic about this. So the intended effect is moderation, but in reality, they work with threat. Threat is what they experience in firsthand. With this, I know that I'm going off topic, but to close the idea, although I do not specialize in trauma, it is true that maybe now we can speak of a collective awareness regarding the trauma that isolation and restrictions means on a person. And that is crucial. And I think we must to take advantage of or draw upon this and raise awareness about how this has been happening to people with psychosocial and intellectual disabilities for decades. At the beginning, I mentioned my intention to categorize lessons related to the stage, which I believe are supported by these three reflections that I mentioned. I think that one of the two biggest lessons that this health emergency has given from a structural perspective has to do with personal care and assistance on the one hand, and with institutionalization on the other. When referring to care, I'm not specifically discussing personal assistance in the context of disability. I'm talking about care as an unpaid job that often is provided by disabled women. So this situation has become more apparent post-COVID, and conversations about the value of care work are taking place in many states that have yet to establish reliable mechanisms for ensuring its importance and regulate it. I previously discussed institutionalization and restriction, but it's important to know that from a structural perspective, it's worth mentioning that the COVID-19 pandemic has led to some states to rethink their approach. So one key lesson is the importance of reviewing existing policies or existing legislation with a particular focus on decongregation strategies. I think the reflections I mentioned before have triggered the ongoing policy reviews that some states are having. Currently, Spain is reviewing all existing practices and planning the institutionalization strategy or decongregation strategy. And this strategy is backed by research and pilot projects. I'm kind of optimistic rather than being an empty blank with no substance like the mental health and disability strategies that are on the present. So these issues have come to light since the pandemic, and hopefully they will be on the ground soon. A particular issue that the restrictions imposed by the COVID-19 pandemic have helped to see, I think, more clearly is the issue of gender-based violence and how this affected disabled women. It was found that women, and especially disabled women, when isolated, are more likely to face gender-based violence. So in this regard, the strategies and even the legislation of some European states must consider these kinds of facts and on their measures to respond this type of violence. About the practical lessons, certain emergency measures that didn't take place from the beginning, but then they were implemented, have become permanent, having a significant impact on disabled people. These measures were, for example, providing government information on accessible ways, remote healthcare services, and the ability to work remotely. So these changes have allowed for a more inclusive and accommodating environment that fosters equal opportunities for all. So since COVID-19, states as well as big corporations have been rethinking some issues or raising awareness about home office time and spaces. I know this is a process, and that some states are debating reducing the week work to 4 days, which has an enormous impact on disabled people. However, it is a lesson the states must embrace these emergency measures as a state. But I wonder if this kind of measure could be applied to the entire population with disabilities. And my instant response would be no, I don't think so, because there is an informal an emergency economy within disabled people that is precisely the effect of discrimination and oppression towards disabled people, and that with the pandemic has double the impact. So it's difficult to implement these kind of measures that are more for enterprises or corporations to the reality of disabled people. So efforts, I know, are underway to address and implement solutions for these issues, although they may not be fully resolved. Their impact on society and on the states is there. As I said, I have not just recommendations, are more kind of reflections, and I have four of them. And the first one is that the previous panelist and also the project team mentioned is intersectionality, and intersectionality matters really. So intersectionality provides a valuable perspective, although the term is frequently used in public discourse by politicians. The true meaning of intersectionality often seems unclear. So intersectionality is an important tool for addressing the challenges of our evolving society. When faced with urgent social issues, it is essential to take an intersectional approach. However, we must apply this concept in a meaningful way by recognizing that the real risk factors are not the individual identities like gender or disability, but rather the systemic issues like ableism, sexism, racism, and so on. So that is the risk factor. So it's the same as the social model of disability. We have to take the guilt on the person and to see the system that we are having. So regarding funds, before allocating funds, we need to perform an evaluation. This has been already said from my previous colleagues, but we have all type of recommendations from the Special Rapporteur and from the Commissioner for Human Rights of the Council of Europe about this. And despite states' claims of limited resources, there are resources available. What is required, I think, is political will to protect human rights, not just please part of the voters or part of the constituency. It's, in this sense, I think legal capacity and the right to vote must also be recognized as essential. People with disabilities should be considered equal citizens, not second-class citizens. This, again, this could be very simple, but maybe for us it's very simple, but not for politicians. So inclusive measures must be taken for all, in all contexts, including in emergency situations. About the plan and strategies, one important lesson that we can learn from COVID-19 is the importance of planning, particularly when it comes to funds. This was highlighted earlier today, but it's worth emphasizing that states should prioritize planning ahead. It's also crucial to ensure that disabled people are included in the planning process. And this gives me the space to share something that has already been said here today about the voices of disabled people. And I think it is important to include the perspective of disabled people in public policies and in the decision-making process. The motto, nothing about without us, emphasize this need for inclusion. Although the progress has been made post-COVID, at least in some countries, it is not universal, and there is an urgent need for significant improvements to be made. I would like to add something about digital divide. I don't have a specific recommendation other than the ones already mentioned in here, but I like to share what I have learned in terms of access to technology, which is often a privilege in marginalized groups, including disabled individuals. So the impact of this has been significant during COVID. I had the opportunity to work in a project around Europe, interviewing marginalized groups. And this was the significant finding. Also, this was already mentioned, but in several European countries, education through national TV was not accessible in a way for disabled children and other marginalized groups such as Roma people. So again, intersectionality. So I had the opportunity to work in this project, and this was the major finding, and the access to technology, it's a privilege for disabled people and other marginalized groups. And to finish with what I started, I would like to emphasize that as academics, it's important to step outside our comfort zone, I believe, and expand expand, the conversation on human rights, which includes the rights of disabled people. So it's interesting to observe the different perspective on disability, even within the same discipline, particularly when it comes to respecting the will and preference of disabled people. So while the values and ideas behind the CRPD are gaining ground, there is still work to be done to fully integrate them into all areas of research. So I believe that the project, this amazing project, results and the results should be shared everywhere and outside the usual suspects that we already know. We have to spread the word of the results, because it's really, really, really important, as you already said. So that's all. Thank you so much again.
Laura, thank you very much. And thank you also for grounding those recommendations, those reflections, I think, in the paradigm shift that we often talk about, the values underpinning the CRPD. And I think your point about the fact that societies have now experienced restriction and isolation themselves can be a really important way for us to advocate for policies that are much more inclusive of the experiences of people who have experienced institutionalization and other forms of intersectional discrimination. So thank you very much for those excellent remarks. We will now turn to the second speaker on this panel, who is Corinna Rufer, who joins us, I believe, from Germany. She has worked for a self-help organization of persons with disabilities and later as an assistant of a member of the state parliament in Rhineland-Palatinate in Germany. She became a member of the Green Party in 1999, and until 2013, she was elected spokesperson of the Green Party in her region of Trier-Saarburg for 10 years. In 2013, she was elected to the German Bundestag. There, she is responsible for policy making on disabled persons. She is a full member of the Committee on Social and Labour Affairs and is the chairwoman of the Greens in the Committee on Petitions. Corinna, you have the floor.
Well, thank you so much for the invitation to your conference, Disability in Times of Emergency, which I find is a pretty perfect title. I was asked to tell you from the political point of view a little bit about what you call learned lessons and recommendations in respect of the COVID-19 pandemic in Germany. Unfortunately, I must admit that there has not been what we would call focused, analytic, nor political debate about the situation of persons with disabilities during that time, at least yet. What no one could deny is that the last 3 years have been truly problematic for all of us, but some have been hit much harder than others, many persons with disabilities amongst them. The development of an inclusive infrastructure came to a standstill in Germany, even though there's so much to do, since Germany is a world-leading country in keeping up highly segregational systems. We know that quite well, since the UN CRPD committee told us so in May 2015 at the latest. We are legally bound to grant the right of inclusive education to every child. Instead of doing so, we keep up a bunch of special schools. The idea every type of disability gets a specialized school in order to support the kids as best as possible. What happens is pretty much the opposite. 75% of the students leave school without any accepted school leaving certificate. The percentage of students going to special schools stays firmly between 4 and 5%. Their percentage of kids without any school certificate, though, lies around 50%. That means we leave all those kids practically without a chance to be employed in an inclusive setting on the general labor market. Many of constrained to live their lives under exclusive circumstances in nursing homes, facility for the so-called handicapped, in a sheltered workshop, clinics. Those places are, as we know well, in many cases, no safe spaces. There is a high rate of persons who experience violence. The number of women who had to suffer sexualized violence in so-called sheltered facility is twice to 3 times as high as amongst the rest of the population. To understand what happened to people with disabilities, we need to register and understand this background. With the realization COVID-19 pandemic would reach us, the situation was accompanied by shocking pictures of body bags piled up in front of hospitals in Bergamo and elsewhere. From no one talked or even thought of the obligations we have to meet out of the ratification of the UN Convention. Nothing about us without us played no role in respect of the most vulnerable in our society. At that time, we had a Secretary of State for Health who gained a lot of power during the pandemic. He was much criticized because not everything went well during this term, of course, such as the lack of provisioning vaccination, enough vaccination, accessibility of important information was insufficient. He is said to have contracted dubious mask fears and so forth. At some point, he said something we all can remember well. He said, "When this is over, we will have to forgive each other for many reasons." He is right with that. What we don't know as a society, what we should forgive exactly. As I told you in the beginning, here are some things I would like to point out. Many of them have been discussed in your work. It seems to me that there are a lot of parallels to the other countries you have examined. Persons with disabilities, their relatives and friends had a really hard time to get masks, tests, and hygiene supplies. They also had big trouble getting the vaccination, especially if they don't live in special facilities. Some had to beg for months to be allowed to get in line first. In care homes, people were isolated over months. They weren't allowed to visit anyone, nor could anyone come to see them. In some cases, they couldn't even leave their rooms. Until only a few months ago, they had to wear their mask when they would leave their room to walk through the hallways, get into the kitchen or other common used spaces of the facilities. Special schools were closed much longer than other schools. Homeschooling was a joke in many cases. Families were at their limits. No assistance, no therapies for a long time. Many kids suffer because their mental health is at stake. Constant fear of the potentially fatal infection with COVID-19. All the pandemic-related measures were said to be chosen to save the lives of the most vulnerable. Fact is that very many human beings who lives to COVID-19 lived in nursing homes or other special facilities. Many of them didn't even get to a hospital, critical care and intensive care units. They didn't get it. That makes, in the second period of Corona, 60 to 70%, according to the published statistics of the Robert Koch Institute in Germany, were not getting into a hospital before they died on Corona. Nonetheless, the private professional society of the physicians in the field of intensive care thought of guidelines in case of a triage situation which would have led to the situation that elderly people and younger ones with disabilities wouldn't have had access to intensive care units at all. Fortunately, 9 persons with disabilities complained in front of the Constitutional Court and won. The legislative authority was to pass a bill to save people with disabilities from being discriminated against. Unfortunately, the German government passed one that is still not conform with our Grundgesetz, our constitution. Another complaint is expected. What is to do? We need a close and broad examination to understand what has happened in the last 3 years of the pandemic. Therefore, it needs a serious participation of people with disabilities themselves, of course. Overall, we need to radically implement the UN Convention. Exclusion has to end. It's dangerous, we've learned in the pandemic. Some in Germany have the political will to protect human rights, particularly in the crisis. But it's not what the majority thinks yet. So there's a lot of work to do. I thank you.
Thank you very much, Karina, for this challenging, but I think very, very important intervention. The points you make, particularly about raising these issues higher on the political agenda, I think is a shared challenge for many of us across the disability rights movement. And we are pleased to have your support here today to continue with that close and broad examination and really to push for much greater participation and inclusive policies going forward. Thank you very much for your intervention here. We now turn to our third speaker on this panel, and I'm delighted to introduce Hernan Sampietro. Hernan is a social psychologist and PhD candidate at the University of Barcelona. He is a user of mental health services, a human rights spokesman, and MAD activist at Activament Catalonia Association. Hernan, you have the floor for 15 minutes. Thank you.
Thank you. I want to thank the organization for inviting me to participate today for this magnificent closing conference and for the response project. I have to say that the organization offered me, and I have accepted, a translation service because I don't trust my pronunciation and the syntactic correctness of my sentences. Maybe we need this service, but I will try to do it in English. I'll be brave, but please tell me if you prefer that I use the translation support if my English level is not good enough to be understood. First, I would like to contextualize the perspective from which I speak. I am a member of Activament, an association constituted and self-managed by people who are users of mental health services. We were born as a mutual support organization. That is our essence. It is not something that started with the pandemic. I will share our situated experience of people with psychosocial disabilities. Like everyone else, since the pandemic crisis, we have adapted to work online. For example, of our 17 mutual support groups, 15 have returned to being face-to-face and 2 continued operating online. What we saw during the successive lockdowns for the COVID-19 crisis is that many people were no longer able to participate in our activities due to material economic limitations. A lot of disabled people, especially people with psychosocial disabilities, are poor, deeply poor. For example, not everyone can afford Wi-Fi at home, or also for not having a secure environment in their home to be able to participate online. In other words, during the toughest times of confinement, maybe those who needed it the most were left without being able to access a space of mutual support. Second, I do not want to dwell on the relationship between the pandemic and mental health, although Kalina, for example, has already explained it to us today very well. But in summary, here in Catalonia, the data from the health department tell us of a significant increase in various indicators. the number of a new service user of mental health services, a percentage that has increased more in adolescents and women, especially with the higher incidence of eating disorders, self-harms, and anxiety and depression disorders. The number of psychiatric hospitalizations admissions for both people with the first mental health crisis and relapses. The medicalizations of life disconforms was already the common practice before the pandemic, but now the number of people consuming prescribed psychoactive drugs has grown significantly. And these prescriptions are being made not only in the mental health care network, but especially in primary health care. In other words, we have seen that both the situation created by the COVID-19 pandemic and the lockdowns themselves caused mental health problems, and they also aggravated problems for those of us who previously had a psychosocial disability. At this point, I would like to highlight that we learned, or should have learned, that lockdown is harmful to psychosocial well-being. First, if before the pandemic, psychiatric hospitalizations units functioned as inhuman territories, that is, as spaces in which human rights are cancelled, during the pandemic, there was an increase in this violation of human rights. There are some things that we cannot know because there is no public data in Catalonia. There are not even centralized records. For example, how many admissions to psychiatric hospitalization units are voluntary and how many are involuntary? How many mechanical restraints are applied in each psychiatric center, or for how long are they being applied? How much of the medication uses is voluntary and how much is involuntary, etc. But there are other situations that we do know about. For example, during the pandemic crisis, exit or visit permits were prohibited. An admission meant being inside the psychiatric hospitalization unit for the entire time that the crisis lasted or that the psychiatrist considered it necessary, and without the support and presence of our affective support environment. Moreover, this situation not only affected hospitalization units, but also psychiatric residences. During the times of successive confinements, the residents went from being housing resources to lockdown centers. In addition, during 2020 and part of 2021, home admission disappeared from the service portfolio as an alternative to hospital admission. Home admission is a result that has existed in Catalonia for some years, which is voluntary and it avoids hospitalization. But during the COVID-19 crisis, even if the person had an appropriate environment and the support of their family, all admissions were made in psychiatric hospitalizations units. Likewise, even before the pandemic crisis and currently, the health system often treats us as if we were a different type of being, so that we go to psychiatry like someone who goes to the vet. I say this because many psychiatric patients are treated for other health problems within psychiatric hospitalizations units. For example, a colleague from Activa Men named Laia Arqué, who suffered from cancer, shared her photos on social networks to denounce that she was receiving her chemotherapy in a psychiatric hospitalization unit. And this remained the same for COVID-19 as well throughout the pandemic crisis. The health system did not transfer people with psychosocial disabilities who were admitted to psychiatry to specialized units for COVID-19 care or pulmonology units. For example, another Activa Men colleague who was admitted to psychiatry fell ill with COVID-19 and was locked in an isolation cell for 3 weeks so that the disease would pass there. We have just said that lockdown is harmful to psychosocial well-being, but it seems that for people with psychosocial disabilities, this learning does not apply. The standard response to the ill effect of lockdowns for us was more lockdown and more isolation. So here, the basic recommendation is the repeal the laws that, for example, as in Spain, the Article 763 of the Code of Civil Procedure and the reform of the Patient Autonomy Law, which are the laws that rule the involuntary treatment and legal exceptionality in the healthcare for people with psychosocial disabilities, or to repeal of equivalent legislation in the different member countries of the United Nations. Fourth, Since the lockdowns and restrictions due to the pandemic crisis ended, in Spain, for the general population, the occupation and employment data have been improving until currently reaching occupancy rates that are not only prior to the pandemic, but also prior to the financial crisis of 2008. It is a good time for employment in Spain, even though wages have lost purchasing power due to inflation. Regarding people with disabilities in general, the data has remained relatively stable compared to what it was before the pandemic. In Spain, we have legislation that promotes the hiring of people with disabilities in the ordinary market, and we have civil society organizations that work to promote that this legislation is complied with. But this legislation does not specify the type of disability. For this reason, if we analyze the data based on the type of disability, the final image is very different. Thus, for example, for people with sensory disabilities, unemployment rates are slightly higher than those of the general population. This situation worsens a bit for people with physical disabilities. The problem is even greater for people with intellectual disabilities, and people with psychosocial disabilities are in the worst place. In this sense, according to the Spanish Office for Disability in the Labor Market, among people diagnosed with severe mental disorder who are not disabled for work, 73% are out of the labor market. Regarding the protected market in Spain, we have a special employment center, which is a legal business model whose purpose is or should be to facilitate the transition of workers with disabilities to the ordinary market. But this is not what happens in practice. A report from the General Union of Workers prior to the pandemic told us that in Catalonia, the transition rate from the protected market to the ordinary market ranges between 1% and 5%. In other words, what should work as a springboard to return to the ordinary market actually works like a spider web. Instead of promoting people, they are a finalist resource that traps them. Furthermore, this report warned that the special employment centers keep the best workers, the most productive people, instead of promoting them to ordinary companies. Currently, with the progressive increase in people who end up in psychiatric services since the pandemic, and with the barriers and discrimination that exists in the ordinary market for people with psychosocial disabilities, what is expected is that more people go to special employment centers, not because they need a support system and necessary adjustment to return to the ordinary market, but simply because they need a job, making it more difficult for people who do not need the support and adjustment to access the protected market. In this area, the recommendations are, firstly, to guarantee compliance with the Spanish General Law on Disability or similar laws in other countries, which establishes that all companies and administration with 50 or more workers must reserve a 2% quota for people with disabilities. That is, 1 out of every 50 people hired must be a person with a disability. This is not even complied with by public administration. And in practice, non-compliance with this law does not entail any sanctions. In addition, since not all disabilities face the same social barriers, it is necessary to legislate to promote positive discrimination with economic benefits or a specific tax exception to promote the hiring of people with psychosocial disabilities in the ordinary market. This already exists in Spain for intellectual disabilities, but not for people with psychosocial disabilities. Finally, if we have learned anything or should have learned during the COVID-19 crisis, it is that the mental health presupposes and requires psychosocial well-being and inclusion in the community. The need to strengthen community ties, combat isolation, and promote mutual support should be basic lessons that the pandemic leaves us. In this sense, I would like to end by using the Barcelona City Council's mental health plan as a model for how things should be done. And I put the quotation marks because it should really be called an emotional well-being and social inclusion plan. In Spain, the health powers are of the autonomous communities, the regional governments such as Catalonia, Andalusia, Galicia, etc. The city councils do not have these powers. Therefore, they do not manage health resources, such as hospitals or mental health services. And since they do not have these powers, the Barcelona City Council plan is not designed from a biomedical care perspective, but with a 100% community perspective, not psychopathologizing people without diagnosis, aimed at vulnerable groups, but for the entire population. It will take a long time to explain it, but just one example. One of the programs in this plan, called Consultam, Ask Me, is aimed at addressing the discomfort of adolescents and young people. The Consultam spaces are in the community, in civic centers, youth centers, public libraries, etc. People can access without an appointment and receive the accompaniment of psychology or social work professionals with whom young people can talk about what happens to them without psychiatric labels, without medicalization, without psychopathologization, addressing the life situation that generated discomfort, acknowledging their suffering, not treating them as mentally ill for suffering. These are the kinds of results we should be promoting before, during, and after the pandemic. Thank you.
Thank you so much, Hernan, and congratulations. From my side, I fully understood that. It was also inspiring, your final example there, to show that a new direction of public policy is actually possible, that it is possible to develop inclusive communities, for those communities to be supported by public authorities, and to prevent us falling back in this pathologization or medicalization of persons with disabilities, and particularly persons with psychosocial disabilities. So thank you very, very much. So now I would invite all of our panelists to rejoin us on the screen, if you would like. And we will be opening the floor for questions. I do already see one question that is directed to Corina, if she is still with us. Is she still with us?
Yes, I am.
Corinne, thank you. So we'll kick off with you first, if we may. This is from the European Network of Ex-Users and Survivors of Psychiatry. And the question reads, do you know of any measures supported by the German government to address the mental health issues developed as a result of the pandemic and lockdowns, especially for children and youth?
No, as I said, I don't have the impression that there's like a focused point of view on people with disabilities at all. And we just now have started to talk about especially kids with psychiatric needs and what we can do for them, and we try to measure the number of them. And so I can't tell you there's like policies to work with or against those problems. I can't tell.
No problem. Thank you very much, Corina. And it reminds me of a comment earlier, I think, from Teresia Wegener, who said, if we fail to count, then we count on failing those populations affected. So that's an important aspect of this. Hernan, there is a second question that has come in also from the European Network of Ex-Users and Survivors of Psychiatry. It's addressed to you. It says, Dear Hernan, you are such a knowledgeable expert, including in the field of legislation. I wonder if and how you have been involved in the policy making and monitoring during COVID. Hernan?
Yes, not only I personally, but as Activa Men, we participate in the elaboration of this Barcelona Council mental health plan. That is why we said no, that they have this perspective, no, because I don't know how to translate it. Maybe I will use the translation service for this. In Spanish, we say de la necesidad virtud, from the necessity virtues. Yes, when you don't have something, you take profit of the other things, for say, no. And this change of perspective was for me, yes, is basic thing, no. we attend that other necessities that affect us, our wellness, our psychosocial well-being. We are participating in different spaces here. In Catalonia, the user and survivors movement have a space to participate, not only in that one. For example, now the government of Catalonia is doing a step forward to go to a zero restraint in all the spaces, not only in mental health. I will say it in Spanish because I'm suffering. I explain really bad. I will say it in Spanish. Maybe they will translate me. Actualmente se está promoviendo una política que va encaminada hacia las contenciones mecánicas cero y que tienen que ver o se aprovecha del hecho de que en Cataluña la sanidad está privada aunque se pague con dinero público, está concertada. Entonces, lo que se está haciendo este primer año, en todos los centros de atención donde se aplican contenciones mecánicas, hay la obligación de comenzar a registrarlos e informarlos. Por primera vez, el 2023, va a haber un registro para saber...
There is no English interpretation at the moment.
Ah, there is no. I'm sorry. Okay, I will try to translate it myself. Okay, I'm saying that this year, for the first time, we have the obligation to every not only mental health center, also who work with old people or with children, yes, to have a registration of the mechanical restraint. For the first time, that will be obligated to register. And from the next year, every year, they will have to reduce a percentage, or that will penalize the money the services receive from the government. Yes, they are going not for the low way. Yes, because the government of Catalonia cannot change this kind of laws. Yes, but as they pay the health providers, yes, they go for the economic way. Yes, they have a strategy to reduce mechanical restrictions in this way. I'm not sure if I were able to explain it myself, but we are participating in different spaces that are trying to change or the legislation or the practices. And this is in Catalonia. It's not only for us. The different no government organization of youth and survivors are invited to participate.
Thank you very much, Anan. And I think there was a bit of issue with the interpretation in and out, but actually what I understood is that it sounds like there's an extremely positive set of practices developing in the region there, which also looks at the economic tools to change the practice of service providers. And I think that's a really very, very interesting point. It's also one I know that is contained within the guidelines on deinstitutionalization, progressively reducing the financing in a very practical way so that we actually get those institutions closed and that we get those coercive practices ended. So thank you very much. I think the gist of your message definitely came through. I now see also that Teresia Degener has her hand up. So could I invite you to unmute? Hello, Teresia.
Thank you very much, and thank you for allowing me to come in here. And I wanted to thank all three panelists for their incredibly good presentations on lesson learned and when we need to go, what is still missing. I really like what Karina said about that we are really missing thorough analysis what has happened in the last 3 years. And I really also like what Hernando said about how important it is that issues of violations are counted and linked to economic sanctions. And what I wanted to just add is that if and when we start analyzing what happened in these years of COVID-19 in each country, we also need to look at where did the rescue money go. I know that in many, many countries, rescue packages were also given out not only for the general business, but also for disability service. And as far as I can see in Germany, it all went into institutions and in the more traditional services, and it did not follow the human rights. Money should follow the rights, and money should not follow the institutions. And that's what I think is the biggest lessons learned also from the COVID-19 pandemic. So thanks to all the three panelists for their insights. Thank you.
And Theresia, thank you very much for your insights. I think you've given us an important focus there, including looking at the rescue and resilience funding that was made available to countries across Europe, which there is increasing evidence, as you say, that those funds have been placed into the old segregating institutions, reinforcing them. And I think, and I imagine that this will be a significant aspect for which the European Union will be reviewed by the CRPD committee at the next periodic review. It will be important for us to raise these issues collectively. Colleagues, we still have a minute or two. I don't see any other questions in the Q&A box, but perhaps what I suggest we could do is invite each of our panelists to give just a closing remark or thought on one of the ways forward. And perhaps to kick us off, I think drawing on Theresia's point there needs to be an approach or a method that we apply when we are assessing public budgeting that is designated to responding to emergencies, one that is explicitly grounded in the human rights standards that we have been discussing today, and the binding legal obligations on all of our states, or many of our states, and the European Union. It seems to me that when budgets are being developed and considered, there is a real lack, in my view, of a human rights-based analysis and a human rights-based approach to budgeting that really protects us against these new segregating or resegregating practices from emerging. So that would be perhaps one lesson we could take from your important intervention, Theresia. Maybe I could offer the floor to our other three panelists for about a minute or so, if there's any final reflections you would like to go with. Could I perhaps come to Laura first?
Yeah, I suppose that what Theresia begins to say in the keynote speech and what she just said is like resume everything. And I think that we have to, when we talk about human rights, we need to include disabled people, and we don't have to take for granted that this is no from all of the, I say politicians because they are in power, they have the power to change things, but we also need to take that power. We have to make that balance, and we need, I mean, the voices are there, we just need to give some space. And maybe from our area, I'm an academic, from the GPOs, maybe we can do something to give the space to the voices to make the effort for, you know, to understand the CRPD and the values of the CRPD for the people that can change things. And the other thing that you was saying and that you were saying about, and also I remarked something in the reflection about the funds and the budget, we need to, and this, I think there are several recommendations about this, and in terms of COVID, I would like to see where these funds are going, and also not just the funds, also the plan, the strategy to use the funds. I can see, I have the opportunity to see, for example, in Spain, there's a lot of public money and it's a very big budget, but maybe for politically, I mean, for politic, you know, race and they want to do it all now because the government could change for a right hand very soon. So they want to do everything, but they are doing not in the correct way. So also in not just in terms of the funds and the budget, but also the plan for use that money. I believe it's important.
Thank you very much, Laura. I give the floor straight to Corina for a moment.
Thank you. In my opinion, as I tried to point out, there's a great danger that we will see resegregation, and we need to act against that. My impression is that many politicians, but also many people, don't understand that inclusion means to follow the human rights of everybody. Yeah, it's not understood, at least in Germany, what inclusion really means. And that it would be good for all people in our countries to transform us into inclusive structures. And during the pandemic, we saw the opposite. We saw that the dignity of people were at stake. And the hardest example for that are the discussions about the triage. Yeah? Who will get access to intensive care? And I think we need to help people understand that no one wants to live in a society where the most vulnerable don't have the right to get access to medical care, etc. So that's what I take into the German parliament and try to point out every day. Thank you.
Thank you very much, Corina. And I finally bring in Hernan for a final remark.
I just want to say that I agree with the things that were said before. It's not a question of the budgets. It's not a question of the quantity of money, but of the perspective. For example, more and more is being spent in medicalizing social unrest. And another reflection that I need or made now is what or where is the community? Community mental health services are outside hospitals, but here function like ghettos. The people go there and only because it's diagnosed, and the relationships are only with other diagnostic people or with the professional who care for them, but they are isolated of the rest of the community. This is not a community resource. That's not inclusion.
Thank you, Hernan. And can I take this opportunity to thank all of our incredible panelists for this third panel. It's been a hard but an important discussion, I think. Thank you, Laura. Thank you, Corina. Thank you, Hernan. Thank you also to all of the interpreters and those who contributed to this discussion. And I'd be pleased now to hand back over to the response team, who have my highest commendations for the organization of this event. Thank you.
And thank you, Stephen, for your excellent chairing of our final panel for today. It falls to me then for the final few moments that we have of our conference today to act as a rapporteur and to try to feedback what I feel are some of the main points which have emerged from our exchanges today, as well as some of the key threads and commonalities which I think we can and should take forward in our advocacy and activism on the rights of persons with disabilities in times of emergency. So at the start of today, we opened with that powerful keynote address from Theresia Degener, where she outlined the disproportionate impact of the pandemic on persons with disabilities, a theme which has run throughout our discussions today. And also another element which has been common throughout many of the contributions we have heard is the impact and the historic impact of gaps and deficiencies in data collection, which has meant and resulted in the lack of a clear picture regarding what has actually happened to people with disabilities during this public health emergency. Theresia very helpfully and concisely and clearly outlined the
specific rights that within the CRPD which are relevant to public health emergencies such as the COVID-19 pandemic, and importantly highlighted that these are not derogable rights. These are not rights which states can roll back on or indeed rescind their obligations on when faced with public health emergencies. The core theme, I think, if I'm correct, of Theresia's keynote is the importance of the human rights model of disability, as has been developed by the CRPD committee in its interpretation of the UN Convention on the Rights of Persons with Disabilities, and how central to that human rights model of disability is the concept of personhood, and personhood not being linked to constructions or concepts of capacity, of functional capacity or mental capacity, but based on those central principles which we see in the convention and find in its general principles of equality, of dignity, and of respect for human diversity. Our responses to that keynote added valuable contributions and insights around public health decision-making at both a national and international level. And both of those respondents, I think, outlined the challenges of ensuring non-discriminatory approaches to decision-making, as well as identifying the failures which occurred in terms of the inclusion of people with disabilities in those decision-making processes around both policy and clinical practice. Again, from that, I took the very clear need to raise awareness of human rights obligations amongst health and social care professionals going forward. In our first substantive panel, then, our thematic panel around healthcare, we received 3 incredibly informative and fascinating contributions from Caoimhe, Sigrid, and Olga. Caoimhe reflecting on the health and social care professional perspective in terms of the really an ever-changing landscape from a clinical perspective, and the way in which resource constraints played into and interacted with decision-making around things like ICU capacity and triage. And I thought her reflection and her identification of a phenomenon which she called the pandemicization of decision-making, allowing concerns around resource constraints and surges in capacity to influence care decisions was a very key learning and output, which I took from Caoimhe's contribution. Sigrid then very helpfully identified the pre-existing issues particularly around accessibility, which existed in the German healthcare system, and failures, really ongoing failures based on that legacy, to ensure the provision of accessible information concerning COVID-related healthcare during the pandemic. That failure, again, to prioritize people with disabilities in terms of the provision of PPE, both to the individuals themselves and those acting in a caring capacity for those individuals who, as I'm sure we all know, can often be disabled people themselves. And fundamentally, I took from Sigrid's contribution the need for the inclusion of people with disabilities in decision-making at all points throughout public health emergencies, such as COVID. Finally, Olga highlighted the very important and distinct experiences of people with psychosocial disabilities and their experiences of healthcare during the COVID-19 pandemic, adding, I think, a wider lens as well, a broader European perspective, a very valuable information about jurisdictions which we on the Response Project did not include in our analysis. And really, I took from Olga's contribution the compounding effect of the pandemic on people with psychosocial disabilities. So the issues such as institutionalization, isolation, and increased coercive practices, as well as the important role, I think, of international bodies, as Olga highlighted, such as the Subcommittee on Prevention of Torture, in providing some level of oversight during emergencies like these, particularly where other oversight and monitoring mechanisms may have ceased to some extent at a national level. We then moved on to our education and employment panel, where Elaine, Paolo, and Monica all gave incredibly informative contributions around experiences of education and employment. Elaine's very powerful explanation of the experiences of deaf people in Ireland, the impact of the pre-existing barriers on deaf people in terms of receiving information, access to education, and the increasing of employment barriers which had already existed for that population prior to the beginning of the pandemic. But I was heartened to hear of some of the positives which Elaine drew out of her presentation as well, the increasing awareness of the importance and role of sign language, of Irish Sign Language in particular, given its statutory recognition in Ireland. The fact that there appears to have been a wider provision of interpretation services, which continues to this day, and that many people, many deaf people, found that remote employment had particular advantages and worked well for them. Paolo gave us the very important perspective of Italy, who, as we have recognized, is held up as an example, particularly in the context of inclusive education. He noted certainly that there was a good base there for inclusive education, but that nevertheless, e-learning and the transition to remote learning for some students created issues in terms of accessibility and that ongoing issue of digital divide and exclusion. Monica very helpfully laid out the way in which the alternate path which Sweden took in many respects during the pandemic played out in the context of disability, that focus on individual responsibility, as she identified, but that this placing of responsibility on individuals was hampered again by a lack of accessible information for individuals, as well as a mixed impact of distance learning and remote work for individuals in Sweden. And then in our final panel, we heard from Laura, Corinna, and Hernan about lessons that they have taken from the experience of the pandemic, as well as recommendations going forward. So we had very valuable insights from all three participants there. Lara highlighting that our CRPD obligations are still not fully understood by those in power. And I think that recurred throughout that panel, the important role of politicians and those in political power in ensuring their greater understanding and engagement with the obligations which are contained within the convention. Laura also reflected on the balance which was struck throughout the pandemic between paternalism and autonomy. And I think really it struck a very important note regarding the way in which the experiences of people with disabilities suddenly became far more understandable and perhaps relevant to other members of the population when faced with restrictions on their liberty and decision-making and autonomy during the crisis. Corinna has set out the debate in Germany about the impact of the pandemic on people with disabilities and the impact of ongoing discriminatory practices leading to lifelong disadvantage in many cases when children are placed in segregated education, for example, that tends to be a funnel by within which it is very difficult to leave once within it, as well as the impacts on children with disabilities on their education. And again, Corinna very much highlighting from a political perspective the importance of the participation of people with disabilities in the review of what has occurred in the pandemic, as well as reform for the future. And finally, Hernan really brought home other intersectional impacts for people in particular with psychosocial disabilities and experiences of mental health services, the impact of poverty and digital exclusion on that group of people in Spain. And again, a lack of data, particularly around the use of coercive practices such as forced medication and other practices which exist in institutional settings. And again, that clarion call really from Hernan to ensure that obligations under the CRPD to abolish laws which allow for the involuntary detention and treatment of person, that those laws and policies are repealed. So from that, I would like to suggest some overarching threads which have emerged from our discussions and exchanges today. First of all, the very disproportionate impact of the pandemic on people with disabilities, but also the very distinct experiences of certain groups, and that it is not possible to draw homogeneous conclusions around people with disabilities in general, and that indeed our legal and policy responses need to take account of that diversity and difference which exists when we talk about reform and review for the future. I also took from our conversations the compounding and multiplying effect of the pandemic on pre-existing inequalities and discrimination experienced by people with disabilities, as well as the ongoing failures to consult with people with disabilities and consequent and in many cases foreseeable rights violations which occurred throughout the crisis. Throughout the day today, I think we saw both implicitly and expressly the important role of civil society and of DPOs in particular in advocating for the rights of people with disabilities, but that in many cases, those organizations needed to do far more than they should have in order to both raise awareness and to prevent further rights violations. I also take from our conference today the need to ensure that pandemic changes and adaptations, as well as future planning, take into account the need for support, accessibility, and reasonable accommodation as fundamental benchmarks in any legal and policy processes and exchanges. And also at the very core, the crucial role of international human rights law norms, primarily the UN Convention on the Rights of Persons with Disabilities, but also of other UN and regional oversight bodies in doing what Theresia has highlighted as being necessary, building back better. Again, the need for accurate and current data, so updated data, is obviously crucial to law reform efforts and any recommendations being effective. And towards the end of the day, I think very much the conclusion being drawn that there is a need to follow the money in that sense, in terms of how monies and funding are being used on the ground to ensure that they are being used in a CRPD compliant way. And finally, that the pandemic isn't over for many people, both in terms of the ongoing lived experiences of people with disabilities, the decision-making that they are continuing to have to do, which is perhaps has a different risk assessment than other members of the population. I think we are at risk of forgetting that, as well as the need for radical, inclusive reform of almost all aspects of our society, given what we have learned about what can happen and has the tendency to happen in public health emergencies. So with that, it just remains for me to sincerely thank all of our contributors today, as well as the members of the audience who have stayed with us throughout what I have found to be a really stimulating, challenging, but encouraging discussion as well around the ways in which we can respect the rights of people with disabilities in emergencies. As Stephen has just mentioned, these analysis and recommendations of the experience of people with disabilities during the pandemic, both within the response projects that we have been involved with, but also conscious of other research which has been and is being conducted in this area, it has real potential to impact on legal and policy reform, and also particularly of timely relevance given the CRPD Committee's forthcoming general comment on Article 11, that provision which addresses the rights of persons with disabilities in situations of risk and humanitarian emergencies. So with that, I would ask you and encourage you all to go to the Response Project website, which the address for which one of my colleagues will add to the chat box in a moment, which brings together all of our research and recommendations in this area. And I do hope that this will be an ongoing conversation that all of us will have in order to ensure that the lessons learned from the pandemic are taken on board and feed into legal and policy reform. Thank you very much, everyone, and a very good evening.